Armstrong's actually the director of that, but that's okay.
I think the director for
Have to give her, yeah. So, so again, Eric's title. Again, the answer is no, I don't. You do not need 3D glasses. I'll answer that one before we go. There's my faculty. And contrary to what was spoken earlier by Dr. Horlick, the Toshiba lab, if you have the right equipment, actually is very, very advanced as opposed to what Dr. Horlick said earlier. Yeah. He's not listening, so that's okay. So it's not an audience response system, but how many in the room right now have the capability to do 3D RA? More than 50%, probably 60, 70%. And then if you do have it, how often do you do it? Routinely? A couple of hands. Occasionally? Same hands. Rarely? Fewer hands. Never, I hope. There's no nevers if you spent the money to do it. Okay, good. All right, so we already know the good elements when we're just doing two-dimensional angiography, selective injections. And I mean, the thing to get Chuck fired up is when guys were looking at ASDs back before there weren't devices and you were sending them to surgery and people did a PA angiogram. And just, he went crazy for that. So selective injection, dense contrast load, acquisition, et cetera, and multiple axial projections. Now, this is something and we're all in an effort to try to reduce radiation, and as you get into 3D rotational, that's one of the comments about 3D rotational radiation dose, just like CT. And this was actually a digital acquisition and fluoroscopic with some of the technology that we use. So we do a fair amount of fluoro record rather than digital acquisition which helps immensely. Obviously, pulmonary artery anatomy is really difficult in 2 dimensions, and there's lots of reasons for it. All right, fluoro recorder and the angles. So you'll see a standard frontal and lateral plane, obviously in PA anatomy doesn't really help so much. We need angled views, and one of the difficulties is figuring that out. And a lot of times in the congenital world we have lots of other obstacles when we're trying to image, as you can see here. So complexity of the second, third branches of pulmonary arteries with all the other interference. And then, of course, when you have all of this, you have difficulty with other types of imaging, maybe not CT. And again, this is not really an issue with 3D rotational angiography. So here's an example at our institution. We do a breath hold, usually 1.5 to 2 milliliters per kilogram. We use diluted concentration in the babies and small infants. A lot of times we'll do rapid RV pacing to keep the contrast where we want it. It's actually 200 to 10 degree spin at 4.1 seconds. So we give it over 5 seconds. The AWS system of Toshiba usually is back within actually about 5 seconds now. And then we can now use 3D overlay, roadmap fusion for the interventional procedures, which I'll show an example. So you can take the data set from the 3D. It is a CT. So what you're doing is a CT. And you can take that data set just like CT and make measurements, et cetera, that you come up then with your volume rendered 3D image. This is really what you're doing, just so you understand. What you're looking at is a cylinder. As the spin goes around, there's a cylinder of all of the data that's in between all of the anatomy. And so, for instance, this is after some of the sculpting, and you can see as you just go through everything, we turn it. All the guys in the Cath lab can do this, all of our staff, till you end up with pretty pictures. This is an example, as you can see, with aneurysm after balloon angioplasty and after covered stent. And then this is a patient that actually was on ECMO, had an ICAS stent and severe coarctation in PDA, and ultimately the ICAS stent was expanded, and you can see the ICAS stent actually kind of going around in circles. This is a patient that came to us that was in Russia and had a rescue NORD procedure, and one of the things that was missed, and see if I can do this right down here at the bottom. If you look right here, the shunt, on a regular angiogram you couldn't see this, but there's severe narrowing of the shunt as it's compressed, and so we couldn't see this on angiography. You couldn't see it on the lateral view. This is a patient after hybrid stage 1. This is transesophageal atrial pacing during the 3D rotation, and one of the things that we missed during our standard angiogram was, in fact, we had not covered the entire PDA. There was an area here, and they ultimately developed stenosis here. So this is, again, a complicated patient, interrupted aortic arch, had discrepant lung scans, echo was negative, Holter negative, MRI, there was question of LPA stenosis, so here's your Fontan, And here's the angiogram. You can see the LPA doesn't look bad from looking at these pictures. You can see another closer picture, and at least in the AP projection and even in the lateral, there's not an obvious. There's the LPA up above. And then here's a rotation, and you say, well, still doesn't look so bad. But then when you do the rotation, you spin it, you look from the patient's head down, you'll see that it's compressed. And what you find out from your CT scan, you can actually tell what it is that's compressing as well. And this patient ended up with stent therapy, and you can see that the 3D made it very easy to see where the problem was. And as I mentioned, you can find out anatomic structures that play a role that we don't usually think about. I mean, we kind of look always intravascular. We don't really look at all the other tissue structures like you see here. So I think that 3D rotational angiography, because it is a CT scan, also helps us understand anatomic structures that our surgeons are well aware of. So again, understanding this is after the patient had stents and moved things out of the way, just like this. Single rotation gives you the best angles to work in. That's another important feature. When you do your rotation and you reconstruct, you can figure out exactly the perfect angle for the intervention that you want to do, and that's where you put your. There's actually a function from the 3D rotational that you just do autoangulation, and from the 3D it'll go exactly to the angle that you want it to go to. So again, complex anatomy map, as you can see here, some complex PA stenosis, which is easy to see, and then what you'll see the angles being down at the bottom of the screen, and you can go to the angles that you want. Here's a patient with complex MAPGAs and pulmonary atresia VSD. And then one of the things that we do with the single injection, you can take each MAPGA and you can color each one. It helps your surgeons as well, and you can determine distance from where they are from each other, so when they talked about their unifocalization procedure. This is an example, for instance, of a complex little Jehovah's Witness baby that had heterotaxy syndrome. You can see all the things: dextrocardia, pulmonary atresia, non-confluent PAs, bilateral PDAs, unbalanced canal, bilateral SVCs, complex total veins. And so this was just the starting angiogram. And so another audience response: would you do a 3D rotation? Because we're trying to figure out where everything was, because our surgeon, Mark, is saying, why can't you just stent those PDAs? I don't want to take him to, it's a witness. I don't want to take him to the OR, fix his veins, and put him on bypass and all that kind of stuff. So he says, you need to stent both PDAs. And so the answer was, for us, yes, we did that. So here's an example. Again, you can see that when you look at the 3D, you say, well, that's not that helpful. But then when you reconstruct, you can see the stenosis over in the left PDA, the right PDA. You can see the anomalous venous return. And that's with a relatively small amount of dye. This is contrast, and this is after the PDAs have been stented. And again, it gives you a robust examination of all the complex anatomy. So this is, of course, our team always has fun. Here's one of the devices after fenestrated Fontan was closed with a device. You can make colors, and the staff usually does these kind of things. The other thing that Darren Berman, who's one of my colleagues, when he was with Evan Zahn at Miami, because they were very interested, even way before we were, about 3D rotation. Evan was a Siemens user, started with the Toshiba engineers. And one of the things that they wanted to figure out was, can you do accurate quantitative measurements from the CT portion, not the volume rendered, because you can make that look whatever you want. And can you do accurate? So what they did was, basically they looked at patients with non-pulsatile system, and Darren wrote this up. When you look at the RPA and LPA, because it's an average, your 3D rotation, again, is an average, but with non-pulsatile, it correlated very nice with angiograms for the RPA and the LPA. One of the other things was, we said, well, we really like to put sometimes structures together. And so here's a SVC and an angiogram, a caval pulmonary angiogram, and here's the Fontan from below. So what you'd like to do is put them together. Again, here's a caval pulmonary with the aorta, with stents in both, and what is the relationship with each other. And so what you'd like to do is you'd like to see them together. And at that time, we didn't understand about dual injections, but shortly thereafter, you can see what we did was, when we first started, we had two catheters and we had two dual injections. The spin was performed. We had another injector on the floor-mounted, one on the ceiling, and we had to step on. We stepped on both of them at the same time. Well, one of our staff said, you know, it would be a lot easier if we just used a single injection, same catheters, exact same size, exact same, and just split your Y connector. So we basically now just have just like you're doing your angiogram, you split it to both catheters. The catheters have to be exactly the same because the flow rates and everything has to be the same. And you put them in, you do a single with a single injector, and you get both injections. So it's much easier to do now. So here's a patient that's after a switch pulmonary artery aortic angiogram. And you can see, again, the anatomy, how everything relates when it drapes over the aorta, et cetera, which we kind of know anyway. The other thing is, because in our hybrid OR suite, we have the ability to do the spins. It's a little more difficult in the OR because you have bypass, you have anesthesia guys kind of running all around, as you can see here. So here's a spin afterwards, after Mark did a comp 2. You can see everybody kind of getting out of the way. It's the same process in there. We try to educate everybody in the OR just like we are in our cath lab. And then you can see a standard injection that's an exit angiogram. And then again, you can do rotation. You can spin everything and look at any of the other anatomy, much more with a single injection because you can't get the different complex angles in the OR. So this is very helpful. So someone was asking, I think, when they were talking to Eric, well, what do you do about some patients that have issues? And you're worried about the coronaries, but you can't. I think it was someone balloon dilating a stent that already had an aneurysm. I don't know if whoever was showing had a little tear. So here's a patient, a 12-year-old, had a homograft, had fungal endocarditis, now comes back with severe stenosis, suprasystemic RV pressure, and pulmonary regurgitation of the homograft, and you can see what that looks like. So here's a spen on the patient. The surgeons, of course, said, we don't want any part of this patient. We're not going to take this patient to the OR, etc. We'd like for you to fix this. So we did this spin first, and it was pretty ugly. And so we actually did IVUS and some other things as well. And so the idea was they're not going to operate on this little girl. It's all kind of, her front chest was not so good. So we had to figure out a way, and just like what we were talking about earlier, what we did was we're not going to balloon dilate this to figure out what size to put in. So what we ultimately did is we placed on small balloon catheters, we checked where the coronaries were down the barrel. Then we put covered stents to line it, 2 covered stents to line from top to bottom to kind of just enclose it. We didn't care if there was still stenosis. We let the stents just go where they were, a small balloon, like a 12-millimeter balloon. And then ultimately, Palmaz XL stents, and then the Melody valve afterwards. And so, again, you're sometimes tasked with difficult issues. And yes, we worried about the coronaries. We tried to see where they were from the start, and then just slowly, inch by inch. But I think that's what Eric was talking about as well. Sometimes you just go slow. And there is some risk with that. But we stop at a certain point in time. We don't try to get it as large as it could be. And that's what the 3D looks like afterwards. Well, this is really the new part. So what about 3D rotational angiography and fusion, like Eric was talking about? I believe, we're at Toshiba Lab. I look at all the vendors equally. Siemens has always been very much ahead of this. I mean, they've always been ahead of even 4D fusion and a lot of things. They spent a lot of time with this, and that's their ICMR and everything else. Very nice job. I think the ergonomics of the lab suck, but other than that, I think it's good. Philips has a great. Yeah, you can't stand anywhere. I mean, you can't do anything from the head. You got to. So, at any rate, Philips has and was alluded to, a very nice Echo 3D system. Very nice. There's only one to have it right now. When you put your little dot and you go around. Very, very nice. And again, Toshiba, they bought Vitrea, which was a CT workstation, CT company. And so now what we did, you have to have the upgrades, but you can integrate all the radiology, Vitrea and PAC system. You can now register any CMR or CT, which you could with Siemens for a number of years, register it into the cath lab so it doesn't have to be done at the same time. We put the little marker, we put a little contrast so we can register it AP and lateral, so you can bring that in and use it as a fusion roadmap. And then it's very efficient and quick. The AWS system, which is the angiographic workstation, it's a super fast. Like I said, it's really back in about 5 seconds before you even have to reconstruct a 3D. And this really helps accuracy for the interventions, and it reduces the need for multiple injections. And ultimately, Scheim wrote a nice paper, and the radiation dose is controlled. So this is what it now looks like in our lab. So here's Darren. He was doing a live case during 3DI3, which Eric was alluding to. And you can see Eric and Brian over here. And this is the way our monitor is set up. So you can see this is actually an MRI that's been registered into the lab. And you can see the patient, and we have all the screens set up, and they have a preset protocol that Darren and the guys developed. And so this is what it looks like. So as you can see, they're doing a live case. They register. They go ahead and, as you're moving the catheter through, they're going to go into the RPA at the same time. And you'll see, just like you do with the ICMR, you'll go into the RPA and you'll see it go down into the RPA over here on the bottom left. And then afterwards, you'll see that now they're going to manipulate with the wire now on the RPA. They're going to manipulate the PA. They're going to bring it up the CT scan, so you can put the contrast up and down on the CT scan. You can do measurements. You can see the things up in there's lots of things moving at the same time. So this is all laid out in front of you, and everybody's moving. The team in the lab is well versed at this, so it's not the physician dependent. So this is kind of what we do now with our multi-format monitor. Here's an example of a patient, and this is just a very short example of the fusion overlay with one of the stents going in for coarctation at the same time. So again, this is really where we want to be. I think Siemens still is one more step ahead of people with some of the 4D fusion flow that Amy and the people talk about, and others are trying to catch up. Well, the advantages of 3D rotational, it's a single injection. It's limitless angles. You can do accurate quantification, but its caveat is, again, it's an average. Its relationship to all the surrounding structures, you can't really get any other direct way in the lab. And of course, you're viewing the 3D structures in 3D. The disadvantages, it's a new technique that you have to learn and your team has to learn. It's new technology to buy. There's static images, 4D, as I mentioned about Siemens. 4D fusion is here in Siemens with flow analysis. And there's an expense to go along with this. So again, it's here to stay. I think Eric already mentioned. I think as you think about this in your lab, if you don't have it or if you have it and you want to do upgrades, I think it's going to improve all of the performance in your lab, but particularly interventional, some of the interventional procedures. I think it ultimately will prove to reduce radiation. It's no worse radiation than biplane and actually in some series now it's less because we use fluoro record a lot of times. It's going to improve our assessment of our interventions because you get to see the rest of the anatomy around it. And so it's been quite a, I was not resistant to it, but my other guys were really pushing this hard. So I have to give Darren and the team quite a lot of accolades for this. And again, it's a pretty picture, but it's more than a pretty picture. One of our teams, Paul, said, yeah, it's more than a pretty face when he did this. So with that, there's my new grandson. Thank you very much. And the moral. I was the holder.
Anyone have any questions?
John, who does the processing for your rotational?
So when Darren came from Miami originally, he was with Evan, and they're the only guys that did. Evan did all of his own reconstruction and everything, so Darren learned from that. When I brought all of that technology to our lab, I prefer not to do anything that I don't have to do. So I have probably 6-7 people in the staff that can do all of this. While you're still standing at the table and doing stuff, they reconstruct everything. You can send it back and forth from the control room, and they do all the pictures that now Darren doesn't do it anymore. He lets the staff do it because you can keep working while they're doing it. So I personally think you as a physician need to understand it, so you need to learn about it. I don't know what you do right now, but my staff does all of so it makes it efficient.
Yeah, in our lab, the MRTs do the reconstruction, and we have that other system that we don't have.
Yeah. Yeah, you also stand. I've seen where you do your from the head cases. Yeah, standing in left field.
In any case, they do the reconstructions. It's very fast. It
Yep.
takes less than a couple of minutes, we have table-side controllers, so we
Right.
can adjust it to the
Up, down, the angle, and also your contrast, so you can, as you got all your stuff inside, you can just go up, down while you're working real time, so you can see everything up, down. So
While I'm not convinced about using the overlays for the interventions as much,
Yeah.
with Fusion, and like I think what I really get out of the 3D images is that you learn much more about the anatomy than you can see with 2D imaging. And you can think in your mind about where exactly that stent should go in relationship to the other components of the anatomy that you would never have an opportunity to see with just a single measurement.
So one of the things about the overlay that what we did was because one of the things when you're bringing in outside CT or MRI and you register, there's no wires in there. There's no stiff wires anywhere. So it does move your anatomy. So one of the things, because we are using now the Fusion overlay like a lot, and we weren't initially, but now we try to put the wire. Before we do our 3D, we try to put the wire where we think we're going to do for that intervention, and we put it and we do the spin with the wire in place, and then it registers beautifully. It's very, very accurate. So.
Okay, great.